Good evening, everyone. I would like to welcome you all to our Insights program this evening with Professor Timothy Bickmore. And first, I would just like to introduce Dean Larry Finkelstein from the College of Computer Information Science. Dean Finkelstein joined the university in 1983, and he became dean in 1994. Prior to coming to Northeastern, he was a professor of mathematics at Wayne State University in Detroit, Michigan. Some of Dean Finkelstein's expertise includes development and algorithms and the application of the solution of large-scale problems. Also, he's very busy on campus as well. He was on the search committee for the president. He is also one of the pioneer leaders for the university's successful application to NSF Connections Program, aimed at connecting the university to the Internet 2K. So at this time, I would like to welcome Dean Larry Finkelstein.
Well, I'm still a professor, too. Well, first of all, I'd like to welcome you all to this event, and I'm glad to see so many alumni here. And I'm also glad to see so many alumni of the college. And, you know, it was kind of always surprising to see our alumni when they've been out like 15 or 20 years, because they we used to only see them wearing suits when they actually, you know, were looking for co-op jobs. And then they looked so uncomfortable, like the pants were too short and the jacket didn't quite fit. You know, but it's, you know, but some of them I still remembered. Some of them look just the same, like Daniel over there, except his hair is a little shorter. But it's my great pleasure to introduce our speaker today, Tim Bickmore. And Tim has really been kind of the leader of our program to really incorporate the use of technology in the healthcare sector. And I've been kind of like, I take healthcare as kind of a religious mission here because, number one, if you're in Boston, 10% of the NIH research budget comes to Boston. This is just a great center of research in biomedical healthcare work. And I think the number of people working in the sector is somewhere around 40 to 50,000. So I've been telling my faculty that finding great problems for computer scientists to work in healthcare is like taking a picture in a Grand Canyon. Just point and shoot. And there are so many great problems that computer scientists can actually have a major impact, where they can see that impact played out in the lives of people. And Tim, a lot of what I know about how to apply computing to the healthcare sector, I've learned from Tim, and Tim has spent time educating me. And he really, we hired him. Tim got his PhD from the Media Lab and MIT Media Lab, and then spent 2 years at BU as an assistant professor at BU Med School. So we learned a great deal working there about actually the complexities of working in the healthcare sector. And the healthcare sector is pretty complicated. A lot of people who want to apply their knowledge of some other discipline to the healthcare sometimes aren't fully aware of how complex that sector is and how you have to work within all the regulatory environments, the professional guidelines that physicians have. And it really takes a lot of learning besides just on the underlying science itself. So Tim will talk. Tim's area of specialty is about, one of his areas is about relational agents, and if you don't know what relational agents are, you'll soon find out when Tim introduces you to the stars Laura and Tinker. So Tim basically has also worked in. Tim had before he got his PhD, he actually spent a fair amount of time working in Silicon Valley as a professional developer. So he comes to the college with a whole variety of skills besides just his specialty, which is about relational agents. And he also has been, his work has been very prominently featured. He's received numerous awards, including an NSF Career Award, which is basically a large-scale investment by the National Science Foundation in junior faculty with great promise in order to advance their careers. Just recently, his work on the virtual nurse was demoed for Catherine Sebelius, who's the Secretary for Health and Human Services, which is a great honor. And I know that aside from other things, the range of people interested in his work is pretty broad, including the Chief of Naval Operations, if I'm correct, who is the Navy actually has large number of boats without medical personnel on board, without full doctors, and they're very interested in the kind of telemedicine that can be applied to really take care of the sailors on those boats. So Tim's been a great asset to the college, and without further ado, I'd like to introduce Tim, who will describe his work to you. Thank you.
Thanks, Larry. Okay, I was instructed to turn this off. Let's see. There we go. Thank you, Larry. And I'm going to try to not knock this water down, but we'll see if I succeed in that. So just to contextualize my work a little bit, I'm situated in the College of Computer and Information Science here. And these stats may be off a little bit, but I think they're the right orders of magnitude. And in particular, we have a program in health informatics, a master's program that's been going on for a couple of years, fairly successfully now. We're in the process of putting together a PhD program in this area as well. So we have a lot of interest within our college in the space of health informatics, and of course at the university level as well. Within the college, in my lab called the Relational Agents Group, and I'll say why we call it that in a few minutes. It's an interdisciplinary lab, so I have between 12 and 20 students working with me typically, and they're from all different departments and colleges across the university. So most of them are from computer and information science, but I usually also have students from our animation program working with me, and you can see some of the more animated members here amongst us. Students from exercise physiology, because a number of our projects have to do with exercise promotion, so getting people to do more physical activity. Students from industrial engineering, when we have to build physical things, and other departments as well. Oh, nursing, we often have nursing researchers work with us. Okay, so what is it that we do? So in a nutshell, we try to build this. We do a lot of studies of one-on-one, face-to-face conversation between health providers and patients. So doctors talking to patients, nurses talking to patients. We go out and videotape them and try and study these counseling sessions that are typically just a few minutes in duration to try and understand all of the intricacies that go on in this detailed dance that the two of them do while they're talking to each other. So part of it's what they say. And within the speech channel, we look, of course, at the therapeutic content of what the doctor's trying to tell the patient to do or suggest they should do, but also looking at social and relational behavior as well. So a good health provider who has good bedside manner will try to build trust and rapport with the patient and what's called a therapeutic alliance, which is getting the patient to want to work with the doctor or nurse over a period of time to try and correct their health problem. And that's been shown in a number of studies to be a significant determiner of outcomes. It makes patients more satisfied with their care. It makes them more likely to listen to what the doctor is trying to tell them, and because of that, they have better health outcomes. In psychotherapy, it's the single biggest determiner of outcomes in a number of different problem areas. Okay, so that's all going on in the speech channel. There's also lots of nonverbal behavior going on as well. So there's the use of hand gestures for conveying information. People often wave their hands around while they're talking, and it's not just random behavior. They're actually communicating information. The use of eye gaze cues to signal turn-taking. So when the patient's being asked a question or when the doctor wants to hold the floor and say something. The use of eyebrow raises and head nods to emphasize certain points that are being said. And facial displays of emotion. So trying to show compassion and caring and empathy for the patient as a way of building this trust and therapeutic alliance over time. So what I want to do is take all of this behavior and put it in an automated computer system for the purpose of some kind of health intervention. So trying to get people to take their medication, to exercise more, to remember their doctor's appointment, these kinds of applications. And so if I want the computer to be able to do hand gestures, I have to give it hands. And if I want to have it do facial display, I have to give it a face. So the systems that we end up building end up looking like this. So this is our virtual nurse that we have over at Boston Medical Center. So if you get admitted to the hospital there's a good chance you'll get discharged by our virtual nurse. We wheel this up bedside just before you're ready to go home, and you have about a half-hour conversation, sometimes it could go up to an hour, about all the things you need to do to take care of yourself once you get discharged. So what you need to do in terms of medication taking, your follow-up appointments, pending lab tests, things you should ask your primary care physician about, and so on. So I'll talk a lot more about this and show you a demonstration in a few minutes. But basically, the style of the conversation is the character talks to you using synthetic speech. The reason is because we dynamically assemble everything the character says based on the patient's medical record, based on discourse context, what was just talked about, questions that the patient's asked. So it's all dynamically tailored to the situation and to the patient's condition. So characters talking using synthetic speech and a dialogue engine. And it's also using animated nonverbal behavior. So these hand gestures, eye gaze cues, head nods, and so on that I was just talking about, synchronized with the speech for appropriate natural delivery. And then when it's the patient's turn to say something, they would love to be able to talk to the character, and we'd like that too. But in order to work reliably in the hospital context and at home, we present them with a list of options on the screen, and they touch what they want to say. So in a number of different health applications, we found that this takes about 10 seconds for a patient to learn how to use. You just say, touch what you want to say, and that's pretty much it. And it's extremely reliable. There's no uncertainty. There's no guessing what the patient's actually trying to talk about if we allow them to do unconstrained speech or typed text input. Okay, so why are we doing this in the area of health behavior? Well, it should be obvious. Health behavior, if you can just get people to stop smoking, eat healthily, exercise more, take their medication as prescribed, you can have a huge impact on public health. It's the major driver of health and healthcare costs in the U.S. And so if we can automate some changes in health behavior, even if they're very small changes on a population-wide level by automating things, we could potentially have a big impact. Okay, so why cartoon characters talking to patients about their health? That just seems on its face like a silly thing to do. So one reason is rapid acceptance across a wide range of patient populations. So we have a lot of patients at Boston Medical Center, which is a safety net hospital here in Boston, who have never touched a computer before. A third of U.S. adults have low health literacy, difficulty understanding healthcare concepts. A lot of them have issues with reading literacy. Across all of these different patient groups, we find that they can learn how to use this interface in the same amount of time, and they're able to use it in an hour-long counseling session or over months of repeated conversations without any problem. Because the interface is presenting itself as a conversation, and everyone knows how to do face-to-face conversation, how to interpret hand gestures and head nods, even if it's completely unconscious behavior. Okay, so this is the first major reason is that we're presenting this interface in a natural, intuitive way that anybody can use. Another reason is for the purpose of fostering this sense of therapeutic alliance that I was just talking about. This is actually what got me interested in this area in the first place. So I'm trying to build trust and rapport and getting the patient to be engaged with and listen to what the character is trying to tell them. And so it turns out a lot of the behaviors that people use in building personal relationships are nonverbal in nature. So things like facial displays of empathy, for example, closer proximity, more frequent eye gaze behavior, more facial animation and hand gestures. And you can try and do some of these things in text, but it's just a lot harder and it doesn't come off the same as seeing it actually displayed in front of you. Oh, and just incidentally, that's also why we're called a relational agents group, because one big focus of our work is on trying to build social relationships or simulated social relationships between computer characters and users for the purpose of making things like health interventions more efficacious. Okay, and a final reason is, again, looking at health literacy. So health literacy is the ability for an individual to read and follow written medical instructions. So, for example, reading the prescriptions on a pill bottle and being able to take them as prescribed. Turns out a third of U.S. adults have inadequate health literacy, have difficulty performing this for a variety of reasons. And because of that, many national studies have shown they have significantly greater healthcare costs, more hospital utilization, poor control of chronic conditions, so all sorts of health problems because they can't understand what it is they're supposed to do. So we've spent a lot of time in the last few years videotaping clinicians explaining written medical information to patients and looking at the verbal and nonverbal behavior they use in explaining to patients exactly what they're supposed to do. And then capturing that in an interface in which the character can exhibit these same nonverbal behaviors to orient the patient to the written matter, describe the structure of the document, answer questions about the document, test the patient's understanding, and so on. All right, so what's with this health advocate? So this is, I'm going to talk about a range of projects and studies that we've been doing, but this is maybe a convergence point for all of this research. And the idea is to ultimately have something that's on your smartphone, that's with you all the time, that's your sort of personal health buddy, if you like, that can work with you to keep you healthy. So it motivates you to exercise, motivates you to eat the right kinds of things, tells you to take the stairs instead of the elevator. If you do get sick and have to go and see the doctor or go into the hospital, it can help mediate your interaction with the healthcare system. So if you have an emergent problem, it can perhaps notify your nurse who picks up the phone and calls you. If the doctor wants you to stay on a particular regimen or a change in your medication regimen, it can help explain that to you and help remind you to do what you're supposed to do. It's personified for all the reasons I just talked about, so it actually presents itself as a character-based interface. It's personal, so it gets to know you over time, so not just the details of what's in your personal health record and what you're supposed to be doing for your health care, but the fact that maybe you like to watch soap operas, and it recommends that to you as a self-motivator or self-reward if you meet your exercise goals for the week. It's portable, so if you have a question or you need some information, it's with you wherever and whenever you need it. And finally, if you can couple this with sensors that can detect health behaviors of interest, we can actually make it proactive. So it can actually beep you when you're trying to decide whether you should go for an exercise or not, or whether you want to go for the cookie or maybe just have a cup of water. Yeah, some people call this the nag bot, but basically can intervene at the points of decision making and get you to change your health behavior in a more efficient way. Okay, so some of the areas that we've been applying this to, in preventive medicine, we've done a number of projects in exercise promotion, so trying to get sedentary adults to do more walking. In diet promotion, both for weight loss and also just to shift to a more healthy diet. Cancer prevention for both exercise promotion and also getting individuals to avoid UV for skin cancer prevention. In the inpatient setting, we're doing a pilot right now with Mass General to educate patients before they come into the hospital for surgery about their options for anesthesia, and the risks and benefits of each, and then how to prepare themselves so that when they sit down and have a consultation with the anesthesiologist, it's more efficient, the patient's better prepared, knows what kinds of questions they want to ask, and they've actually done their appropriate fasting before they come into the hospital. And then on the discharge side, I'll talk a lot more about the virtual nurse, but this is getting patients ready to go home for that hospital-to-home transition. Once they go from the hospital back home, we've built a couple of systems to try and get them to stay on their medications as prescribed. And we're getting ready to field one right now with Boston Medical that will follow the patient home from point of discharge to their first primary care physician appointment that keeps them on their medications and determines if they're having any significant side effects. And then contacts their care team at the hospital so that they can intervene appropriately. And then finally, in the outpatient setting, we have a couple projects going on. One for exercise promotion for geriatrics patients. So this is a Boston Medical Center geriatrics. It's a year-long intervention where we send older adults home with a tablet computer for 2 months. They have a daily chat with the coach about trying to get them out and do more walking. And then at the end of 2 months, every time they come back into the clinic for a regular appointment, we have a kiosk in the waiting room there where they can have sort of a maintenance check-in with the character to try and keep them on their exercise program. And then one that we're just in the early development stages is on preconception care. This is to address disparities in infant mortality and low birth weight for African American women. So trying to get them as healthy as possible before they get pregnant to ensure the health of their child. Okay. So before I dive into a few of these systems in more detail, I'll give you a little bit of what's under the covers. So this is not too technical, I hope. The dialogue engines, yeah, that wasn't meant to be a joke, but I guess you could take it that way. So what drives the dialogue is what we spend most of our time building when we build these systems. A typical counseling system will have between 5,000 and 10,000 states in a big state machine that describes all the things that the character might tell a patient in different situations. And they're arranged in a big bag of finite state machines where typically a node will be something that the character will ask or tell the patient. and then we branch from there based on what the patient says and what's in their medical record and other information. So most of our systems are built using this sort of formalism. Something we've started building in some more recent work uses models of dialogue as hierarchies, so as planning hierarchies. So for example, one way of having a conversation, you start off with a conversation with the characters having a mutual goal of having a counseling chat about your exercise. And one way you can do that is by doing a greeting, having some counseling content you talk about, and then doing a farewell. So that's looked up in a library and dropped in this tree. And then based on what the patient says, you can look up in the library and grab another dialogue fragment. And so, for example, one way of doing a greeting is for the agent to say hello, and then the patient to say hello back. And there may be many other ways of doing this. So this tree is dynamically expanded based on the context of the conversation, and can get, of course, huge by the time the conversation is done. But it sort of dynamically unfolds along with what's being said. And so we can leverage a lot of things in this tree, for example, in generating the language that the character needs to tell the patient. Okay, so whatever the format of the dialogue planning formalism, at some point the character needs to open its mouth and say something. So we basically specify utterances or things that the characters would say like this, just in plain text, so it's for your blood pressure. But we also need to be able to specify all of this nonverbal behavior that the character is going to use. So all of these hand gestures and head nods and so on. And so we specify that using these tags. So for example, this says I want the character to do a head nod and then what's called a beat gesture, which is the most common kind of gesture you see people make. It's just a simple biphasic emphasis gesture. And the position within the text is important because it indicates what we're actually trying to emphasize. So in this case, it's for your blood pressure. That's how we want that delivered. So we can go in and specify all of the nonverbal behavior that we want the character to say in its conversation with the patient this way. But as I said, our typical system has about 5,000 to 10,000 utterances. So it would take somebody with a degree in linguistics a very long time to go through and do this. So what we have do this for us automatically is an engine that I co-developed at the Media Lab called Beat, that takes the text of what we want the agent to say as input, does a linguistic analysis of it, and then decides where to put all of these nonverbal behaviors. So how should this sentence be delivered by a character in the most natural way possible using all of the nonverbal behavior that should accompany it? And just very briefly, the way this works is for each sentence that the character is going to say, we do a linguistic analysis of it and build a parse tree, if you remember from grammar school, basically English grammar. And then we have to keep track of what's been said before, because it turns out that you tend to do most nonverbal behavior on the part of the sentence that delivers new information. And then we have this big bag of rules from studies that we've done and other people have done that say where things like a point should occur or a hand gesture or a head nod, and then annotates the tree with those behaviors. And then finally, all of that gets generated out in the animation. Now, because we have so much dialogue content to develop in one of these systems, we've developed a lot of tools to let clinicians and other healthcare practitioners write a lot of the dialogue content for us. So we have visual tools that let them sit down, write some branching dialogue, and then push a button, and the character pops up and performs that so they can see what it looks like and can test it. And then for deployment, we can deploy to a number of different platforms. So most commonly to a desktop computer, either in somebody's home or in the clinic. This is our cart that we have over in Boston Medical Center. We have 8 of these over there right now. It has an articulated arm, so this touch screen can reach across in front of the bed while the patient's laying in bed or sitting on the side of the bed. We can deploy to PDAs or smartphones, and then we also have a plug-in for a voice XML interactive voice response, so you can pick up the phone and talk to the character also. All right, so let me talk in more detail about some of these specific systems that we build so you can see what this looks like. So a lot of our early work was in exercise promotion. One of the first systems I built was part of my dissertation work at MIT, and this was having an agent talk to MIT students every day for a month to try and get them to do more walking. So actually get away from their computer and get some exercise. So they had about a 10-minute counseling conversation with this character every day for a month. We gave them pedometers to wear so they knew how much walking that they were doing. And one of the things that we manipulated was whether the character used these relationship building skills or not. And so one thing we found is that when it did use these behaviors based on standard measures of therapeutic alliance, that in fact patients felt closer and had more trust and rapport with the agent when it used things like displays of emotion, social chat, meta-relational communication, which is talking about how the format of the relationship is working, and so on. We also increased the amount of walking that they were doing relative to a non-intervention control group. When I got to BU Medical School, we repeated this study with a group of geriatrics patients. So again, this was a group of individuals who had very low levels of computer and health literacy. So half of them had never touched a computer before. We had them talk to one of these agents in their home for 2 months every day. And were able to basically double the amount of walking they were doing relative to a control group over the 2 months of the study. We were also, this was the first study I did with a population that had low computer literacy, sort of at least compared to MIT students. And so we were wondering, the geriatricians were wondering if these folks would even turn the computer on and use it. And in fact, most of them really enjoyed the experience. They liked the social aspect of the interaction. They enjoyed the social chat every day with it and wanted it to do more of that. And so this system, in fact, has gone on to a clinical trial that we're currently running over there right now with 270 geriatrics patients, funded by National Institute on Aging. Another series of projects we did in exercises is putting a health counselor, an exercise coach, on a wearable device with an accelerometer. So the idea is something like this. Every night you would schedule 2 times that you were going to go for a walk on the next day. And then at those times it knew if you were doing it or not, because it could sense from the accelerometer if you were walking or not. If you did your walk, as soon as you stopped, it beeped you and the character came on and said, "Great job." If you didn't do your walk, though, it would try and find out what the problem was, and could it try and motivate you to actually stop what you were doing and go for a walk. So we did a number of studies with this. In the last one, we compared a number of different conditions. This is just simply reminding people that it's time to go for a walk. And this is reminding them it's time to go for a walk and doing some counseling. So this is sort of context-sensitive counseling. This is just reminding. And then this is doing end-of-the-day counseling. And these are a number of steps walked, basically. So we did significantly better when we did do the context-sensitive counseling. So it indicates that it is promising, in fact, to be able to sense somebody's health behavior and talk to them right at that moment that they're trying to decide whether to, do the cookie or the glass of water. We also did a pilot with Partners Center for Connected Health. A similar format. Folks talk to the agent 3 times a week for 4 months. And in this case, we gave them what's called an Actiped, which is a small accelerometer that clips on your shoe that counts your steps walked. And every time you walk near a computer, it automatically uploads your steps. So we compared our coach to just a website that would display how much exercise you were doing and show that we did do significantly better over the duration of the study compared to the website in terms of steps walked. And we have a couple of other projects that are currently in clinical trial also. So one's a bilingual system for older Latino adults in San Jose, California. We're doing this in collaboration with Stanford Medical. And then finally, this RAISE project is with the University of Rhode Island Cancer Prevention Research Center. That's to prevent cancer by getting people to do more exercise and stay out of the sun. This is a study funded by National Cancer Institute. And it's a year-long daily contact intervention. So people have up to 365 conversations with the character. So we did a lot of work just trying to keep people engaged and coming back and talking to our character every single day. So one of the design problems that we were confronted with in this system is exactly that. Given that people had the choice of whether to continue talking to our coach every day, how do we keep them wanting to come back and use it? They're not getting paid. They're not getting any other benefit from doing this, so how do you keep them hooked? We looked at lots of different ways of doing this, so just varying behavior. So as one of the individuals in one of our studies said, it'd be great if the character could just change its clothes occasionally. So, would keep me more interested, right? This social and relationship building behavior to build trust and rapport, reminding the patient that this is good for their health to keep doing this, telling lots of stories and jokes, In the RAISE system, we actually go out. It's a national study. We look up the weather forecast for their locality and then do weather chat with them. We don't give them a weather report, but say, you know, it looks like a nice day compared to yesterday. And, you know, and last year this time, remember that big windstorm that we had? So it tries to do a social chat about the weather. And then finally, backstories. So having the character tell stories about its own personal history. The fact that it had a fight with its spouse last night and it grew up in Alabama and has, you know, 2 kids at home. And is this a way of making people more engaged with the character so they're more likely to come back and talk to it about their health problems? This brought up the problem of how real should we make these characters? Should they just be fictional cartoon characters, or should we actually try and make them like people with backstories? So we did a study. One of the exercise physiology students working in my group told us lots of stories about her personal history. We recorded these and built a dialogue engine around that so that the character could tell these stories. And we just simply manipulated whether they were told in first person, so about the character itself, or about somebody else that the character worked with. But the story content's exactly the same. And then we ran a study where we had people talk to this character every day for a month, doing exercise promotion, and to see, would it make a difference if the character told these stories about itself as a person or about somebody else? It seems like a pretty subtle distinction. And the platform in which we ran these was funded on this NSF project that Larry was talking about earlier. So we have this standing group of 30 older adults who talk with one of our characters every day. They've been doing this for a couple of years now. We found out that, in fact, people reported enjoying the stories and their interactions with the characters significantly more when it told first-person stories about itself. We were concerned that people might somehow feel deceived if the character starts talking about itself as if it were a real person. And, in fact, there was no difference and very low levels of dishonesty overall. But most importantly, what we were interested in is what was their actual behavior. And when the character told first-person stories, in fact, they were much more likely to come back and log in. So they had many more logins, and talking to the character when it told first-person stories got people involved in itself as a person compared to just telling stories about the same stories about somebody else. So this has sort of opened the door for us now to building storytelling and narrative engines that we can plug into our characters just as a way of maintaining user engagement so that we can deliver health content to them over very long periods of time. Right, so finally, I want to talk about the virtual nurse. So hospital discharge. This is one of these transitions in care in our healthcare system that's been largely broken, that's not been well attended to. There's 40 million discharges a year in the US. Studies have shown that on average they take place in 8 minutes. And in fact, I used to think this was at point of discharge. This is in fact total patient education time during their hospital stay is a total of 8 minutes about what they should do once they go home to take care of themselves. And until last year, there were no national standards on how to do hospital discharge. And as a result of this, only 42% of patients can tell you why they were in the hospital in the first place, could tell you what the primary diagnosis was, and only 37% of them could tell you what their medications are for if you ask them. And because of these problems and other problems with the system, 20% of patients get readmitted to the hospital within 30 days of discharge. Okay? And a third of those are preventable, that were caused either by the patient not understanding what they were supposed to do when they went home, or being prescribed the wrong medications, or other systemic problems. So that turns out to be a very big number, a very big cost driver, and that's our main performance metric in this work, is trying to reduce these preventable readmissions as a patient safety issue. So I've been involved with a team at Boston Medical for the last 6 years now on a project called RED, which is Reengineering the Hospital Discharge. This is led by Dr. Brian Jack in family medicine over there. And they spent a number of years studying their hospital discharge process and trying to fix it, come up with what are the best practices, what's the best way we can discharge a patient from the hospital. And they've come up with this 11-point plan that's now been adopted by the National Quality Forum as a new national standard. And importantly, a number of these steps have to do with patient education. So coming up with a discharge plan that's not written for the doctor but written for the patient so they can understand what they're supposed to do when they go home. Having a nurse sit in the room with the patient, typically for half an hour, to explain this to them. Testing to make sure that the patient actually gets it, that they understand what they're supposed to do. And then having a nurse or a pharmacologist call the patient a few days after discharge to make sure they're not having any problems. So this is the discharge plan that they came up with. This is designed for patients with low health literacy. So it has the contact information that they need, so their doctor and their discharge advocate. And it has, for example, their medications listed by time of day, what each one is for, the different names that it goes by, how to take it, and so on. And as I said, this involves a nurse sitting in a room with the patient for about half an hour on average in their interventions. So that's significantly more than is done today typically. They did a randomized clinical trial, ended last year with 750 patients, comparing this ideal protocol to the way they usually discharge patients, and found they could significantly reduce the number of readmissions. So these are people coming back to the hospital after discharge. So this is the usual care, and this is with their ideal protocol followed. Okay, so they'd like all the hospitals in the U.S. to start doing this, right? Yeah. So there's a small problem. They have to hire a new army of nurses to do this on top of all of their other care that they have to do. So that's when I started talking with Dr. Jack several years ago about using one of our conversational characters to do just this explanation piece of sitting in the room with the patient before they go home and explaining all of their medications, their follow-up appointments, and other self-care to them before we send them out the door. So we received a grant from National Heart, Lung and Blood Institute and also Agency for Healthcare Research and Quality to do this work. It was about a 3-year development process with a team of clinicians. We ended up writing a huge amount of dialogue content, mostly around medications, but also around common diagnoses and follow-up appointments and other things the patient needs to know. We spent a lot of time in the hospital understanding workflow and how to integrate into their systems. And also videotaping nurses talking to patients and explaining the booklet to them so we could capture the same strategies that they used in the system that we were building.
That's one pill.
Okay. And a lot of attention was paid in our design in talking to patients with low health literacy. Because this is such a big problem nationally, and at Boston Medical in particular, half of their patient population have inadequate health literacy. So it has to do with simplifying the language, using pictures and images wherever possible, testing the patient's understanding. So we ask them several questions after each section to make sure they understood it. If they don't, we go back and review it again. If they still don't understand it, we have an alert that gets printed out for their human discharge nurse to come in and explain it to them. Okay, so the way the system works right now is at point of discharge, a nurse sits down and enters the patient's information into our database. We print out the after-hospital care plan. We download a digital version of it and a bunch of data files to one of these mobile carts, wheel it up bedside, and then the patient has this half-hour conversation. It's sort of a sing-along with the paper version of the care plan that we've given to them. And then following this, we print out a report for their discharge nurse to come in and sit down with the patient and walk through anything that we couldn't cover in our system. So any questions the patient had we couldn't answer, unusual issues such as if they were prescribed a medication that wasn't in our library, and so on. All right, so I'll try and show you what this looks like.
Good evening. My name is Louise and I am here to help you with the discharge process here at Boston Medical Center. You are Timothy, is that right? It is great to meet you, Timothy. As you might have noticed, hospitals are very busy places. My job is to make sure that before you leave, you feel that you have been given all the information you need to help make the transition from here to your home as smooth as possible. So, are you Red Sox fan? That is awesome. I would really like to see games someday, but they don't allow computers at Fenway Park. Anyway. So, how are you doing today? That is too bad. Tell me more about how you are feeling. I am sorry to hear that. I bet that it is hard to feel sick, and it is not fun to be in the hospital. I hope you begin to feel better soon. I will now be going over some information with you. It looks like you are going to be leaving the hospital soon. I know you must be looking forward to leaving the hospital, but before you go, I want to review some information with you. This is care plan that we created just for you. Remember to bring this booklet with you to all of your doctor's appointments. On the front, it has your name. And this is the day we are hoping you will leave the hospital. Down here at the bottom, it has the phone number of your discharge advocate. Discharge advocate is nurse here at the hospital that makes sure you have all the information you need before you go home. You can call them if you have any questions about this booklet. It also has the name and phone number of your doctor. This page is a list of the medications that your doctor has prescribed for you. For each medication, the reason you are taking the medication is written here. Here is the name of the medication. Sometimes you might see two names listed here. That just means that the medicine can go by more than one name. Moving on, here is the amount of the medication that you take. And here is the way you take the medication, for example, by mouth or injection.
Okay, I'm going to stop it there. That goes on for about half an hour, depending on the exact medications that the patient's been prescribed and how many follow-on appointments they have and so on. So we've done lots of studies of this system, culminating in the clinical trial that we're currently running. And one consistent finding across all of our pilot studies is once we put this in front of patients with their actual medical data, after this half an hour, we ask them, so would you have rather heard this information from your doctor or nurse? And in fact, only a small minority of them tell us that they would. In the pilot studies, it was 16%. In the actual clinical trial, it's just a little bit more than that. So, of course, we asked them why. And one thing we found is that patients in hospital rooms are starved for information in general and starved for information about their health in particular. So they really like the fact that there's something in the room paying attention to them, spending time with them, that they can talk to as long as they want about their health condition. And also that they don't feel talked down to, that they can ask the same question 5 times over if they want, and they don't feel inferior in some way to the system. Okay, so the clinical trial will be run with 750 patients. We're about 400 patients in right now, comparing to usual care. And just looking at some of the process measures, basically patients are really happy with it, find it very easy to use. We have high levels of trust reported with the agent, high levels of feeling that the virtual nurse cares about them, that they can understand the nurse. And this is the preference again. So only 16% of the patients out of the, let's see, this is 150, say that they would prefer a doctor or nurse over the agent for getting this information. And then we have other interesting results on satisfaction that seems to indicate, in fact, that the patients with low health or computer literacy actually like it more than patients who have high levels of computer literacy. Our guess is that folks who are very proficient with computers would like something that's a little quicker to be able to drill down into the information that they need, whereas folks who aren't so familiar with how to use technology like being sort of led through everything in a narrative. Okay, so what are we working on now? So we have lots of clinical trials out in the field, I think 8 last time I counted, involving, well, it'll be a couple thousand patients by the time we're done. One of the systems that we're just finishing up right now is a follow-on to this hospital discharge nurse Once patients get sent home, they'll continue
Hi,
talking to the
Laura.
nurse
Thanks for signing
on
in.
their home computer.
I am glad to see
over
you.
the
My
web.
name is Louise. We
So
met
it
in
will
the
continue
hospital
to
just
enforce
before you went home.
their medications, and more importantly, will determine if they're having significant
Now that
side
you've
effects
left
or
the
problems.
hospital, we are
and
going
we'll let
to be
the
working
clinicians know
together
so
for the next few
discharge nurse
days
will pick
to
up the
solve
phone
any
and call the
problems
patient
you
if they're
might be
having
having.
So this is funded by Agency for Healthcare Research and
I
Quality.
hope this discussion
And this is the preconception care project I talked about earlier. So one of the things we're focusing on here is getting users of the system to contribute some of the health content, because we actually have 55 different health areas that we're trying to address, and having to write that amount of dialogue content is huge. So we're trying to build a Web 2.0 system so that patients will actually contribute some of the information, moderated of course, that's delivered to other people. And then some of the other fun things we're doing is, we're trying to build a virtual nurse, right? So nurses often touch patients. So this is our TouchBot. So basically it has in this case it's an air bladder. We also have a mechanical hand that can squeeze patients' hands while they're talking to the virtual nurse to comfort them or to emphasize points while it's teaching. And I've done a number of studies. Basically, people who are comfortable being touched seem to actually like this experience more. And for those who don't like being touched, they have sort of the opposite reaction to it. Okay, so all of this range of projects, I think, is ultimately converging on what you'd ultimately like is this integrated system that you have with you all the time that tries to keep you healthy, or if you happen to have to interact with the healthcare system, can help mediate that interaction for you. So I think I'll stop there and see if you have any questions.